Okay, let's make a start. So in this next session, the first talk is from Carla Isabel Borre from Mayo Clinic, Rochester. Is Carla there? Do we have a Carla? Yes, great. Okay, so Carla's going to talk about comparative efficacy of frontline targeted therapies. Thank you.
Carla Isabel Borre. I'm a first-year internal medicine resident at Mayo Clinic in Rochester, Minnesota. It's an immense pleasure to be here today, putting some faces to names I only saw in the literature before this. I'm going to be presenting on the comparative efficacy of fixed-duration chemotherapy and continuous targeted therapy in patients with MAPK-Pathway altered Ardent-Chester disease and Langerhans cells histiocytosis. I have nothing to disclose. And our learning objectives in this study I'm going to be presenting was first to compare the efficacy of frontline fixed duration chemotherapy and continuous targeted therapy for MAPK-Pathway altered ECD and LCH as the title entitles, but also to start to explore how often patients discontinue treatment and for which reasons, if it's due to adverse effects or other reasons. A little bit of background. Targeted therapies, as we've been talking about this morning, dominate the treatment landscape nowadays for MAPK-Pathway altered ECD and LCH. And these diseases have really become chronic diseases. However, targeted therapies are often expensive. They are done in a continuous regimen. They're associated with different sorts of side effects, and are still often unavailable in many settings. Despite this, no trials have assessed the comparative effectiveness of chemotherapy versus the targeted therapies. So we decided to conduct this multi-institutional study to compare these two vastly different approaches in patients with treatment-naive ECD and LCH. So as I was saying, when we think about treatment for these diseases today, for patients with MAPK-Pathway mutations, we usually think of BRAF 600 inhibitors for patients with BRAF 600E mutation, MEK inhibitors for patients with MAPK alterations, and chemotherapy more as a strategy, as a frontline strategy for patients who don't have these MAPK alterations. And although we have several great studies, some from authors here today, showing the efficacy of these different treatments, we still have a gap in the data comparing these different treatment modalities. So we analyzed data from 95 patients with MAPK-Pathway altered ECD and LCH. These patients were consecutively seen between the years of 2007 and 2024 in the 3 Mayo Clinic campuses, Minnesota, Florida, and Arizona. The response assessment was based on standard criteria, on the latest consensus guidelines, and our time-driven analyses were performed from the frontline therapy initiation using the Kaplan-Meier method. Reviewing our PICO question, so we had these adult patients with MAPK-Pathway altered ECD and LCH in the 3 Mayo Clinic campuses. We were comparing targeted therapy to chemotherapy. We defined as our primary outcomes, progression-free survival and time to next therapy, and as our secondary outcome, overall survival. This is a treatment type of questions, and we were conducting a retrospective cohort study. Our inclusion criteria were that patients had to be 18 years or older. They had to have this BRAF 600E or MAPK gain of function mutation. We included ECD, LCH, and also mixed disease, so patients with mixed features of LCD and LCH. If patients didn't have these mutations, or if the mutation was present but they did not receive chemotherapy or targeted therapy as their frontline therapy, they were excluded from the study. We had 25 patients with LCH, 63 with ECD, and 7 with mixed disease. Of those, 19% of the patients received frontline chemotherapy, and 81% received frontline targeted therapy. Chemotherapy was either cladribine, cytarabine, etoposide. One patient received both cyclophosphamide and vincristine, and then methotrexate. And for targeted therapy, either BRAF inhibitors or MEK inhibitors. Looking at our baseline characteristics of the two groups, the targeted therapy and the chemotherapy groups, we had some important statistical significant differences. Patients in the targeted therapy group tended to be older, 58 years old versus 53 for chemotherapy, 43 for chemotherapy, sorry, with a p-value that's less than 0.05. Patients, and we think that's probably an indication bias, so patients with chemotherapy, with an older age being less indicated chemotherapy. Patients in the targeted therapy group also tended to be more male, so 61 versus 33 in the chemotherapy group, and to have more often multi-system disease, 94 in the targeted therapy group versus 67% in the chemotherapy group. And I think that's also related to the fact that patients with more organs involvement, more severe disease, tended to be prescribed this targeted therapy as frontline more often. Risk organ involvement and the distribution of the mutations were both pretty similar in the two groups. And as our median follow-up time, we had 3.4 years for targeted therapy and 4 years for chemotherapy with no statistically significant difference, so pretty similar median follow-up time. Also pretty similar median time to best response, 3 for targeted therapy versus 4 for chemotherapy. And looking at the overall response rate, we did not find a statistically significant difference between the two groups. It was 70% for targeted therapy and 73% for chemotherapy. And we can see that partial responses were more frequent than complete responses, so 60% of partial responses for targeted therapy and 60 as well for chemotherapy. And looking at our time to event analysis, our two primary outcomes, progression-free survival and time to next therapy, we had 76% of patients without progression of the disease at the 4-year mark for targeted therapy versus 77% for chemotherapy with a non-significant p-value. And we also did not have a significant p-value for our time to next therapy. So the percentage of patients without a next line of therapy prescribed at the 4-year marks was also comparable, 74% for targeted therapy versus 63% for chemotherapy. And then for overall survival, again, no statistically significant difference. The percentage of patients alive in 4 years was comparable between the two lines of therapy, 92% for targeted therapy, 100% for chemotherapy. Overall, very high for both cohorts. Looking a little bit at the strengths and the limitations of our study, I think the study has some important strengths. It's based on real-world data. There's an aspect of novelty to the study. We're trying to help answer a gap in the literature. The comparative efficacy between these two treatment modalities is still unclear. And if the efficacy is proven to be comparable as we continue to expand our study between chemotherapy and targeted therapy, then this might have an important clinical application. Patients may have the option for a fixed line of therapy, for a more accessible treatment for settings that don't have this targeted therapy is easily available. However, there are important limitations to mention. This is an observational study due to the fact of how rare these diseases are. This was done only analyzing patients cared for in the US healthcare system. There's a component of indication bias that we have to acknowledge. I showed you some baseline imbalances we had in age and disease extent. And as we are working on the manuscript now, we're planning for a propensity score matching to address this bias. There's also a component of referral bias. Mayo Clinic is a big tertiary center, and we're planning to address this by establishing further partnerships, which we're currently working on. There was a small size for the chemotherapy group, and we did not look into data for secondary malignancies or financial toxicity associated with each regimen. Our key finding here was that fixed duration chemotherapies seem to achieve outcomes comparable to continuous targeted therapy in those patients with MAPK, altered ECD, and LCH. And if that is proven consistently to be the case, that would mean that the selection of therapy should be multifactorial. Yes, considering carefully the comparable efficacy, but also the toxicity profile, patients' preferences, their comorbidities, what kind of resources are available, what are the financial considerations. I would like to acknowledge, first of all, patients and their caregivers. They are the reason we do this kind of work, and all of my co-authors from the 3 Mayo Clinic campuses and the University of Alabama, and give a special thanks to my mentor, Dr. Jitma Abekun, who's here in the audience today. And I'm open to questions and comments now.